take all those images and it essentially goes into their AI-derived algorithm that then spits out something very important. And I'll show you videos of this. But you get real-time, what's it looking like today? Where's the lesion? And you'll see the lesion. And you'll get a CT quality image. You can then get a three-dimensional reconstruction. And you can definitively tell if your tool's inside the lesion. That's unbelievably important. Because sometimes, especially when everyone swore this had to be cancer, and you're busy proving it's not cancer, you're going to be told over and over how much you must have missed it. And when you show them that video and you go, I didn't miss it, can't be more dead center. And then you get the fluoroscopic overlay, the most important part. And again, in this particular example, the lesion's big enough that you can probably have seen it fluoroscopically. But that yellow ball has been marked by you today, right now, intraoperatively. So that is the lesion. And it looks an LAO and RAO, so you can avoid what Dr. Coe was talking about, where you think you're in the lesion, but you're actually like this. Because remember, you're looking at it like this, or you're behind it, right? And you're busy missing. So let's go through what this means. And here's some data from the earliest version. So this was one of the first versions out of this. It's now on its multiple software updates. You'll see that they drove the large scope and then drove this proprietary catheter towards the lesion. And you don't have to use the catheter. But it allows you to get the tool inside the lesion, and you'll see multiple representative examples of how far out you can go and always being able to see the lesion. There is the CT image, there's the tomosynthesis image. So you get quality, and then by the way, this was comparison to CAT scan, so the navigation pathway, and also to cone beam. And was it comparable? Because the whole idea here is, if cone beam's the gold standard, what does this do for you? Well, at their time, they got a diagnostic yield of only 77%. Now again, they weren't using any other kind of advanced technologies, and this was the first version of the software. I'll show you some updated literature, but just to wet your whistle. But what you get is this. You can see it's tracking with respiration. The yellow ball isn't, but your catheter is. That purple line is at least give you a general sense of where you're supposed to be going. And it allows you to then see your lesion. So what came up when everyone said, boy, that first biopsy is the most important, because after that, you're never seeing again. Get yourself inside the yellow circle. You're seeing it again. And then here, this is what the tool and lesion confirmation looks like. So there's the representative CT. There it is today. So that was the CT, the pre-op CT. That's intra-op, using a two-dimensional CR. Preoperative, intraop, preoperative, intraop. 3 planes, you are inside the lesion. There's no debate you're inside the lesion. So if that was your cryoprobe, for example, right before you pulled, you know you're going to make a diagnosis. You don't have rows? That's okay. You're in the lesion. You want to go back? All you got to do is go back into the yellow circle, take your second pass. You want further proof? The AI is able to do this from the same, this is from a 2D C-arm. I have a GE 9900 series C-arm. We bought it 20 years ago, maybe even longer, I don't even know. I'm not sure how much radiation that thing gives out, but it's probably more than it should because it's so old. And so the point there being, what you can do with this. And here's a case of mine. What I show you right up front is this was where the lesion was thought to be preoperatively. You'll notice it's dropped down postoperatively, but I needed proof I was in it. Just using my iPhone to film it. That's Freddie in the background. He's come to see you. Proof that we're in the lesion again. And by the way, what does it add? So let's compare. This is body vision using a GE 9900 CR. Here's the little lesion. Is it as crisp as this? No, but can everyone see it? This is $1.2 million. I don't know what this charges. I know in the US what they charge. I don't know what they're charging in India, but it's less. And it's also less radiation. Less time. You don't have to leave the room for spins. You don't have to acquire a rad tech to optimize your 3D imaging. There's tons of flexibility because it uses any C-arm, and then it allows you, again, to get images that let you see what you need to see. We've been able to do Hounsfield units as low as -640. So as far as like GGOs, you have that. You also have the benefit, of course, of landmarks, right? You know, if the lesion's near vasculature or near ribs, etc., you'll be able to use the other parts of the imaging. Now, this was a small paper that came out from the Cleveland Clinic, 58 prospective cases. The advantage here was that the Cleveland Clinic is multiple different technologies, so they decided just to use the scope and a catheter. Here's just putting the Rebus probe out. Now they were using larger nodules, This is 2.7 centimeter nodules. But look at the tool and lesion confirmation at 93%. They were able to confirm they were always in the lesion. And here's what the video can look like. See? That's it in real time. Preoperative planning. And it moves this quickly. This hasn't been sped up. When you take a look back then at the follow-up paper from the Sasania group, I was in that paper too. Overall diagnostic yield was 88%. And then we combined this with our first generation robot, and we got 91%. That's not been published yet. It's just been presented. The 88's been published. Now again, still not, I think, as high as we'd all like it. But if you actually look at the IR literature, their yields are 90%. They're not 100% either. So now we're trying to reach, I think, finally that pinnacle that we've all tried to achieve, which is I want yields like IR, but I want complications like a bronchoscopy, right? And so we did all this, and the reason my hospital was very interested in this technology is that they're never going to buy me a cone beam. They've flat out told me that, like my own cone beam. And we have so many other specialties that use it that pay better for the procedure with the insurance. I'm last in line always, right? Because, all I do is make a diagnosis. Those guys, throw in a heart valve or a stent or whatever, and, the insurance pays a ton. So they're never going to buy me a cone beam. I don't need a cone beam. That's why we got LungVision. And the nice thing about this, because it's agnostic to what you're using. You want to use it with a robot? Go ahead. You want to use it with a thin scope? Go ahead. You want to use their catheter? Go ahead. Doesn't matter. And the other nice thing from an economics perspective is it was a one-time cost. After that, it hasn't cost us anything because I don't use their disposable. So it just takes the catheter.